these are my notes. At the beginning of my shift, I did a machine check and got emergency airway equipment ready if I need it. I just looked at the chart of a young lady who is here for a planned induction, and I requested an epidural once her Pitocin and everything is going. I didn't see any red flags in her chart, but we're gonna go ahead and talk to her and make sure we consent her before the ball's rolling. Hi, Katie. My name's Tracy. I'm part of the anesthesia team. I understand that you want an epidural once everything's kind of going and the contractions are on their way. Perfect. So I would like to consent you and kind of talk to you all about that first. So that way when you're in pain, that we don't have to have hard conversations. I'm gonna take a look at your name and your date of birth on your wristband. I did look at your chart, but I still wanna ask you a couple of questions about your history. Do you have any allergies? Do you have any meds that you take other than your prenatals? I didn't see any. With your first, I saw that you had an epidural. Did you have any complications with that, or did it work great? Perfect. And I saw your labs looked good, your platelets looked normal, but do you have a history of bleeding disorders at all? And do you have a history of any heart or lung problems like breathing or something like called aortic stenosis or anything? No. And any liver, kidney, or endocrine problems? And then any neurological problems? Any problems with your spine, like scoliosis, or do you ever have surgery back there or anything? No? Okay, perfect. So if you had an epidural once and you want one again, you probably understand the benefits. It kind of reduces the stress and the pain involved with childbirth. We don't want you to have an emergency C-section. That's a whole OB conversation to have, not my conversation to have. I just want you to know that I'll be there, and that one of the benefits is that you could be awake for your baby's birth still. So that's moving on. You may have heard the risks previously, but I just have to go over with you again. It's that you can have back pain, paresthesia, any type of nerve damage, nausea, vomiting, which could be related to hypotension or bradycardia. You could end up with a total spinal or postural puncture headache. Do you have any questions for me about those? And then my only big contraindication would be if you choose not to have one. So if you don't want one, you just tell the nurse, and I don't have to come. No harm, no foul. You're not gonna hurt my feelings. But I just want to be here if you do need me. I'm going to take a listen to your heart and lungs, make sure everything sounds good. I do see into your mouth just in case, and that looks great. So before we sign consent, I want to talk about positioning. So when you're ready, the nurse will get you on the side of the bed. She'll have your bottom as close to me as possible behind you, and she'll have heart rate monitor and blood pressure cuff and oxygen monitors on, so we can keep a good sight on you as long as she's also keeping sight on the baby. So instead of kind of arching forward with your belly out and being more comfortable, I actually want you to, you might remember, I want you to curl your back, put your chin down, shoulders rounded, and curl over your belly like it's a beach ball, and kind of push your back out. You're gonna feel like a cooked shrimp is the best way to put it. And you're gonna feel that I want you to push your back towards me as much as possible, and that helps open up your vertebrae and your spine so that I can stay as midline into that kind of area that kind of can feel closed if you feel that in your back. While I'm putting it there, you might feel like a zing down your leg, like maybe you hit your funny bone, but it feels like it's going down your leg. There's no reason to panic. It does feel weird, but I want you to tell me if it happens, because that way I can kind of know if I'm not on the right track, because we definitely don't want you to end up with like a one-sided epidural, because that's kind of one of the risks as well, is that sometimes they just don't work. Sometimes they end up in one leg over the other leg, but if we have a good conversation while I'm placing it, then we can kind of reduce that risk. I know that was a lot of information. Do you have any questions? I'm gonna ask you more questions during the process, but that just, we're trying to have a good conversation about to make sure that we're not somewhere that's called like intervascular or in the interthecal space. But I'll ask you those questions at the time, so you don't have to try to remember those. Any questions? Okay, I'm gonna have you sign consent, and once you're rocking and rolling, I'll have the nurse call me and we'll get you comfortable. So Katie, you're all hooked up to the monitors. I've opened up my epidural kit. You're gonna hear me kind of fiddle around a little bit back here. I've brought in some fentanyl and bupivacaine to go into your epidural space once that's there. So you'll feel the needle go into your back. Well, first you're gonna feel that I'm gonna kind of poke around into your back first before we get cleaned and everything. I'm gonna feel the top of your hips, your iliac spine, or your iliac crest, the superior part of that. And you're gonna feel me poke around. This is also called your Toofer's line, renal crystal. And I'm looking for your L4, L5 area that I'm gonna, you're gonna feel me put lidocaine into, and then after that, that's a sting and a burn, and then it's just kind of pressure after that. Just like the IV in your arm, there's a catheter that stays, so no needle, and it'll be able to kind of give you continuous medication. So now that I've got that space marked, I'm gonna go ahead and I've got sterile gloves on. This was all laid out sterilely. You're gonna feel me put this underneath your bottom in a totally sterile fashion. I'm gonna get you cleaned off on your back, cold and wet, nothing sharp yet. This is chlorhexidine, it's neurotoxins. We wanna make sure that it dries all the way, scrub a big clean area. And I've got all my PPP on, you're set, the other nurses. You're gonna feel, I'm gonna put this plastic barrier on your back. And we're gonna do so sterilely, so we can keep you clean, me clean, or I'm gonna stay clean so that you stay clean. And when this comes out of a package, it's folded a lot better than me trying to do this over and over again. So this would look different, but we're making it work because it still hasn't touched anything, hopefully. All right, plastic on your back. All right, the rest of my kit ready. Medication-wise, we're gonna numb you up with some lidocaine, that's 1%, and we drew it up with a filter needle, and now we have a 25 gauge needle on that. We'll do a test dose once our catheter is in place, and that is 3 mLs of 1.5% lido with epi. That makes it 45 milligrams of lidocaine and 15 mics of epi. Our main bolus drug before the drip starts, or the infusion, will be bupivacaine, 0.25%, 8 mLs with 100 mics of fentanyl mixed in, making it 10 mLs. I also have my loss of resistance syringe, lubed up and easy to move, and that's got 3 mLs of sterile saline in it that came with the kit. I've got my alligator clip and filter ready. I've got my 2E needle with core in it, and so I think we're ready to go. All right, you're gonna feel sting and a burn. I'm gonna get the outside of your skin first with something called a pinwheel. I'm gonna go exactly where you felt me leave that mark earlier. I'm gonna do a skin wheel, and then I'm gonna go further into your first 2 ligament spaces, your supraspinatus, infraspinatus, and I'm gonna inject all the way in there. And I can kind of come out and go in different directions, and then make sure that the surrounding space is all numb. And now that that's numb, we can get started with placing our 2E needle. I'm gonna use barrage technique the whole time while doing this into that exact same space. I'm gonna enter into the first 2 ligament spaces, so the supraspinatus and infraspinatus. And once I feel like I'm in that space, and I do not wanna go to the ligament flavum at this point, I'm gonna pull my core out and attach my loss of resistance syringe. And the ligament flavum is thick, and it's not gonna let me push this through at this point if I'm not all the way in. And so I'm gonna hold the needle steady, and I'm gonna feel when it gets to the point where it's kind of tough. And see, I still can't go any further. I bounce my syringe against that. I'm gonna look for a pop to feel like I know that I'm in the right spot. If she was not 5 pounds of a mannequin, I would never touch her shoulders on sterile like that, but. All right, so now I felt that pop. I know I'm in the right spot. I'm able to easily, that loss of resistance is totally there. I can see that I'm 8, 7, 6, I'm about 6 into the skin. And I want my epidural catheter to go 5 centimeters past that. And so I know that once it's placed, it'll be 11 centimeters total. I didn't see any like large amounts of CSF come out with that. So I'm gonna thread this in. I don't feel any resistance. So as I pull this out, I wanna keep it sterile. And I don't wanna dislodge my catheter at all. So I can kind of feed it in ever so slightly as the needle comes out. And I want to make sure to keep my needle, or not needle, the catheter sterile. So I can see where we're at marking wise. And I know that the skin, I want to be at 11. Yeah, it's really not the ideal way to do that, but it is working. So I can put a piece of tape there, knowing that we're at the 11 centimeter mark. And I'm gonna do a test dose before I get this all the way taped up. I'm gonna use my alligator clip and insert that about 3 centimeters and clamp that down. I'm gonna do a test dose. So, Katie, I want you to tell me if you feel any ringing in your ears, numbness in your lips or your face, your tongue, as well as that looks for a metallic taste in your mouth. That tells me if I'm intravascular, not in the right spot. And then also I wanna know if you get like a warm feeling in your feet or your bottom feels really numb and heavy right away. That might mean that we're in an area called the interthecal space, and we would want to look at that. And so I'm also looking at your heart rate, making sure that we don't go any more than 20 beats per minute over your baseline. All right, any feelings like that? No, perfect. So we can see symptoms of that over the next couple of minutes, but she doesn't have any at this point. And so we're gonna go ahead and give our bolus dose of the bupivacaine that we set up. And this gets put in at 2 mLs over 2 to 5 minutes. And now that's in, and so we can put a sterile dressing on, tape it up, and kind of put it over her shoulder, and then tell her that she can move around and stuff. We just don't want her to shear her back and move placement on that. We would chart that. We would chart as we're watching vital signs. We would do Q 5 minutes over 15 minutes of vital signs, and then chart our sterile prep that we did, our technique that we did a test dose. She didn't have any reactions to it. The placement, the measurements of where we left it in the skin and how many centimeters are in from that. The positioning that we used, the positioning that we left her in, and then the drugs with the lot numbers on them. And now we're just going to do a quick demonstration of a spinal placement. And as you can see, she is already numbed, she is prepped, she just needs the spinal itself. We have sterile gloves on and the rest of our PPE. We've got a table back here. This is being opened sterile. We've got gloves on so we can move stuff around now. We've got would numbed her up with the 1% lidocaine, just like we already did. It does not have a catheter that you thread in, you just put it in, you give your dose, and take everything out, but you use that same barrage technique that we did earlier. For this, we're gonna use 0.75% bupivacaine, and we're gonna use 2 mLs of that. So we've got that drawn up, we used filter straw. And so we've got our smaller pencil needle. Since we are going all the way into the subdural space this time, we had measured her, we know exactly where we're going. We're gonna use that same barrage technique. You're gonna kind of feel the crunching through that infraspinatus, supraspinatus, infraspinatus, the ligament flavum. And once we're there, we can pull out our core, and we are watching. We're gonna feel that pop as we go through. Oh, there's our pop, so we know we're in the right area. And we are going to check placement. So I've got CSF, I turn, quarter, CSF, turn, turn, turn. I feel comfortable putting in our dose. So we're gonna aspirate, we're gonna see a swirl of the CSF, and then we can inject half. We turn 180, aspirate, swirl CSF, inject the remaining amount, and we pull everything out midline, just like it went in midline. And this is a hyperbaric solution, and so we wanna make sure that we lay her down and get her into the correct position so that it doesn't float and just end up with a saddle block.